going to join, so we'll get started. Good afternoon. Today's class is about jaundice, right? So just like last time, this is going to be a more of a case-based discussion, right? So I need you all to be try to be alert and interactive. So let me first share my screen. Okay, so I hope you can see the slides. Right. So we'll start by recapping some of the physiology and biochemistry that you already know, right? So once you understand the physiology, it's very easy to work out the pathophysiology, right? So this is a diagram from your Lippincott, and it basically demonstrates the metabolism of bilirubin in your body. Now, where do things start? They start with heme, and heme is mainly in your red cells. So the senescent red cells are a major source of heme proteins. What happens to your heme? So as your red cells break down, you have to break down the heme and the protein, right? Or rather the hemoglobin, and then the hemoglobin gets broken down into heme and protein. And then your heme gets broken down into bilirubin. Now, where does all of this occur? It occurs in your reticuloendothelial system, right? Where you get macrophages. Now, heme is broken down into bilirubin, which is in an unconjugated form, meaning it's just bilirubin. It's not a water-soluble substance, so it's bound to protein in the circulation, and then it is transported in the blood to the liver, bound to albumin, right? So because it's not water-soluble and because it is protein-bound, it is not going to be found in your urine, unconjugated bilirubin, right? Now this bilirubin, which comes to your liver, is then taken up by the liver, and in the liver it is conjugated with glucuronic acid and converted into a soluble form, right? Usually this conjugated bilirubin is secreted into the biliary system, right, in the bile, and then through the biliary duct system it gets into the intestines. So it's a conjugated bilirubin that gets into the intestines. In the intestine, you have bacteria. What do the bacteria do? They separate this glucuronic acid from the bilirubin. And this bilirubin is now free, so the conjugated bilirubin gets unconjugated and it gets converted to urobilinogen in the gut. So some of this urobilinogen is then absorbed and enters the portal circulation. And a part of that which enters the portal circulation is going to come back into the intestine through the enterohepatic circulation. The rest of that urobilinogen goes back into the systemic circulation, gets into the kidney, and there it is excreted in the urine. Right? So urobilinogen, when it's converted to urobilin, gives the urine its characteristic color, the yellowish color, right? Some of this urobilinogen remains in the stool, where we call it stercobilinogen, but it's the same thing. And then it can also get oxidized by the bacteria in the stool to form stercobilin, right? So that is what gives the stool its dark color. Okay. So I hope, you have learned this several times, I'm sure. So hopefully this slide helps you to recap what you already know, right? And here we go again, a bit more biochemistry. Red cells are releasing hemoglobin, you get the heme. Heme gets converted in the reticular endothelial system to biliverdin and then bilirubin. It is in an unconjugated form, right, which is not soluble in water, it's protein bound. It goes to the liver, and in the liver it is conjugated with glucuronic acid to form conjugated bilirubin, which is then excreted in the bile, right? So here again, more diagrams just to recap. Unconjugated bilirubin taken up in the liver, conjugated in the liver, excreted by the gut, turns into urobilinogen in the gut because of the action of bacteria. Urobilinogen can be reabsorbed. Some of it comes back in the enterohepatic circulation. Some of it gets excreted in the urine as urobilinogen, right? Which can turn dark on standing when it gets converted to urobilin. And stercobilinogen in the stool also can get oxidized to stercobilin to give it its characteristic color. So this is what happens in the liver. If we sort of zoom in on what's happening in the hepatocyte is taking up unconjugated bilirubin, which is bound to plasma albumin, into the cell, right? And then what happens is within the cell, this unconjugated bilirubin undergoes conjugation. And this requires enzymes and energy. And then that conjugated bilirubin gets excreted into the bile canalicula's, right? So when we talk about jaundice, what we mean is a problem with this pathway. Either there is too much, lots and lots of unconjugated bilirubin coming into the liver or reaching the hepatocyte, or there can be a problem with the uptake of that unconjugated bilirubin. There can be a problem with conjugation, or there can be a problem with excretion, right? So jaundice occurs. Jaundice is a clinical feature, the yellowish discoloration of the skin and mucous membranes. So hyperbilirubinemia is a biochemical abnormality. And jaundice occurs, that means it's clinically apparent elevation in bilirubin occurs when the bilirubin is more than 3 milligrams per deciliter, which is much higher than the normal range, right? So again, to recap, why can this be? It can be due to increased breakdown of heme, leading to more unconjugated bilirubin, as occurs in a hemolytic anemia, right? There's nothing wrong with the liver. It can be due to decreased uptake of bilirubin into liver cells, right? Because maybe there's a problem with the liver cells, or impaired excretion of conjugated bilirubin, which can be either because the cell can't excrete it into the bile canalicula's, or because there's a problem in the duct system. So in a liver disease, or what we call hepatocellular jaundice, you can have both mechanisms 2 and 3 acting in combination. Maybe one will be more than the other, but both of them can occur together. And you can have purely impaired excretion in cholestatic jaundice. Okay, so I hope this is clear, and I hope that you've sort of been able to recollect the physiology of bilirubin metabolism and the principles of the pathophysiology. Right. So let's start with this first case. This is a young man in his 30s presenting to you with yellowish discoloration of the skin and sclera. What do you notice on his physical examination? Anybody likes to comment?
Madam, she's pale and icteric.
Yes, it might be a bit difficult to comment on pallor, but patient is icteric. Okay. What do you think about the icterus? Anything you?
It's a deep icterus, madam.
Yes, this is very deep icterus. That is what we are trying to demonstrate here. So what do you think of when somebody has deep icterus?
Yeah, maybe an obstruction causing obstructive jaundice.
Very sorry about that. My connection got disturbed. Start again. So, yes, I was sharing this picture of a patient with deep icterus. So, what does deep icterus mean to you?
Madam, it might be cholestatic jaundice.
Yeah, so it can be cholestatic jaundice. That is correct. Why do you say cholestatic, and what is it about? Which kind of hyperbilirubinemia is this? Is it unconjugated hyperbilirubinemia or conjugated hyperbilirubinemia?
Conjugated hyperbilirubinemia.
Yeah, so to get this kind of deep jaundice, it should be conjugated hyperbilirubinemia, right? Which can occur either due to cholestasis or due to hepatocellular jaundice, right? I'm really sorry, students. I don't know why my connection is playing up. Where was I? Sorry. Right, so what other features might the patient have? Now, if this is cholestatic jaundice, is there a syndrome of symptoms and that you are aware of, symptoms and signs that relate to cholestasis?
It causes a deep icterus with itching and pale stools.
Very good. So why do each of these occur?
So the conjugated bilirubin and goes and deposits in your cells, and it causes the release of histamine, which results in the itching type phenomena that occurs.
Okay, have you all learned something like that?
It's the bile salts.
Sorry?
The bile salts is the one that is the cause for the.
Yeah. So bile salts, people, I mean, there are perhaps it's a controversial topic, what the cause of pruritus in cholestasis is. So one of the theories is that it's the bile salts. Some theories are that it's related to certain opioids that get accumulated. I haven't heard about histamine, but in general, it's, I mean, the general opinion is, at least at the moment, that it's the bile salts, right? So bile salts get accumulated because if there's obstruction, they can't get excreted into the biliary system. So basically, there's backflow into the circulation and accumulation leading to pruritus. So that's one symptom that they can have. Then they can have pale stools, you said. Why pale stools?
Stercobilin is what gives the color to the stools.
Yeah, exactly. Right? So it's because it's the stercobilin that gives the color to the stools. So if the patient can't, if there's a problem with the excretion here, right, then there's no urobilinogen in the gut, and therefore there's no stercobilin in the stools. The stool becomes pale, right? What about, what was the other abnormality you mentioned? So deep icterus, pale stools, pruritus, any other physical sign or symptom? Abnormality?
Dark urine.
Colored urine.
Dark urine, yes, tea-colored urine. So why will you get tea-colored urine?
It's the reflux of the conjugated bilirubin back into the systemic circulation, which is filtered through the kidneys and into the urine.
Yes, very good. So it's the conjugated bilirubin that gets excreted in the urine, giving it its characteristic color, right? Okay. Fine. So that's a particular syndrome. So when you see somebody with deep jaundice, you're wondering, could this be hepatocellular? Could this be cholestasis? And, you know, deep jaundice, you're thinking more about cholestasis because there's a block leading to conjugated bilirubin getting reflected back into the circulation, right? So then you look for other features of obstruction, which are those, right? So this is the typical syndrome, dark tea-colored urine, pale stools, and pruritus. Now, deep jaundice is very likely to be due to conjugated hyperbilirubinemia. This can occur in obstructive jaundice or cholestasis or in hepatocellular jaundice, more a feature of obstructive jaundice, right? Now, we have an idea about what the biochemical abnormality is. It is conjugated hyperbilirubinemia. What questions can you ask to find the etiology and the complications? In your history, you want to find out now, why does this patient have conjugated hyperbilirubinemia? And are there any complications of that? So shall we just think of what you can ask in the history?
If there is any colicky type pain associated with like bile.
Okay, very good. So you're thinking that there's an obstruction in the duct, which can lead to abdominal pain. So that's very important. So when we think about cholestasis, whether it's painless or painful becomes relevant. If there's something in the duct obstructing the lumen, you can get a colic kind of pain, right? Whereas if it's just a growth outside, you might not have any pain, for example, in pancreatic carcinoma. Okay, good. What else can you ask?
You can ask about the pattern of jaundice. Is it like fluctuating, intermittent jaundice, or?
Very good. So how is that going to change your differential diagnosis?
So in cases of like fluctuating type jaundice, it's like a characteristic feature of periductal cholangiocarcinoma.
So why does that occur?
It occurs when there's a tumor within 2 centimeter radius of the sphincter of Oddi or the major duodenal papillae. And with the and there's bleeding into the tumor, and with that, I'm not really sure of the pathogenesis of the fluctuating.
So yeah, so now if you have, say, jaundice due to a biliary calculus or biliary stone, what kind of jaundice will it be? Will it be intermittent or will it be progressive?
It's intermittent.
Yeah, it could be. It's more likely to be intermittent, or rather, if it is intermittent, it is more likely to be a biliary stone, right? Now, if it's a malignancy, it depends on where this malignancy is. So if it's a malignant stricture, as time goes on, it gets narrower and narrower. So you get a more progressive kind of jaundice, right? Similarly, if it's a tumor at the head of the pancreas that is growing and compressing the bile duct, then also you will get a progressive jaundice, okay? But say if you have a friable kind of tumor at the ampulla, which sloughs off every now and then you can get an intermittent kind of jaundice. So it progresses, and then as the tumor grows and then sloughs off, the jaundice is relieved temporarily, and then it recurs again, right? So that is a very special circumstance. Generally in malignancies, it's progressive, except in the malignancy which involves the ampulla, which is what you're referring to. But anything else you can ask?
We can also ask about the silvery streaking of stools in that particular scenario as well, with the sloughing off the tumor.
Okay, yes. What else?
Features about like gastric outlet obstruction in cases of.
All right. Yeah, okay. So we'll maybe talk about etiology a bit more in the next couple of slides. What about complications? What are the complications you expect in somebody who has obstructive jaundice? Now, cholestasis, you have to understand, doesn't just mean a block in the tube, right? Cholestasis means there's a problem with excreting the bile. So it could be a problem in the cell, the liver cell. And it could be a problem in the excretory pathway. If it's the first thing, where it's a problem with the cell excreting the conjugated bile into the bile canaliculus, we call it intrahepatic cholestasis, right? If it is a problem with the duct system, we call it extrahepatic cholestasis. So both of these give rise to cholestatic jaundice, right? So there are certain liver diseases which cause a cholestatic jaundice because they cause predominantly cholestasis. Right? So maybe that you're not very familiar with that, that's okay. But what are the complications that you will get in cholestasis? Why do we need to excrete bile? And does it have any toxicity if it is retained? Anybody?
An imbalance between the cholesterol and the bile salts within the gallbladder can result in cholelithiasis and
Okay, but cholelithiasis is a cause of jaundice, not a consequence. Now, why are we worried about jaundice? Okay, one thing is the cause may be something dangerous, like a malignancy. But what is the problem with somebody having cholestatic jaundice?
there's an increased risk of gallbladder carcinomas. There's an increased risk of mucocele production, mucoceles.
Any other problems?
Malabsorption.
Bile is necessary to, apart from the fact that you are unable to excrete your bilirubin, you are not able to excrete your bile salts also. So why do you need bile salts? To
emulsify the fat.
Exactly, to increase your fat absorption. So what is the problem with not being able to absorb fat? As wonderful as that sounds.
You'll be bloated, you'll have abdominal cramps and this steatorrhea.
Okay, right. So you might have some GI symptoms. Anything else? Is any harm done?
You'll be malnourished.
Okay, yes. So you can have nutritional problems. Any specific nutrients that you will be deficient in?
The fat soluble
vitamin K.
Yes, the fat soluble vitamins. So what kind of symptoms might they have if they have deficiencies in these?
Like night blindness,
disorders.
clotting.
Clotting problems, yes.
Ataxias and like balance problems with vitamin E.
Okay, so mainly clotting problems and anything else. Vitamin D deficiency, what can that lead to?
Bone problems like bone pain,
Very good. Osteomalacia, isn't it? Right. So they can have complications like that. And then their general nutritional status can also be poor. So how are you going to investigate? Now, your main question when you have a patient with cholestasis is this extrahepatic or intrahepatic? Because your differential diagnosis is completely different depending on which of these it is. So your first step now is to find out the answer to this question. So how can you do that? Biochemistry is not going to tell you. Yeah.
You can do an ultrasound scan and see if there's dilatation of the intrahepatic ducts.
Yes, exactly. Right. So the first step is to do an ultrasound scan. Now, before we move to the ultrasound scan, we will, of course, get a liver function test. And this is the liver profile of this particular patient, right? What do you think? So what kind of hyperbilirubinemia is this?
It's the conjugated type.
It is conjugated hyperbilirubinemia. Yes, very good. So why do you say it's conjugated?
The total bilirubin is the total bilirubin is 5, and they haven't given the direct, but the indirect is 2, so we can assume the direct is 3.
Yeah, that's right. So if you have more than 50% direct hyperbilirubinemia, it is basically direct hyperbilirubinemia, right? So this patient has conjugated hyperbilirubinemia, which is what we suspected based on the clinical features. So what is this pattern of injury? Do you understand what we mean by pattern of injury? When you look at liver function tests, you try to get an idea about whether this is a cholestatic pattern of injury or a hepatocellular pattern of injury. So which of these is it?
It's more cholestatic due to the rise, like abnormally high ALP compared to the normal, like fairly normal AST, ALT levels.
That's right. So you're looking at your ALP and your gamma GT, which get elevated when there's some sort of obstruction. They can get elevated in hepatocellular disease as well, but to a lesser extent. And you're comparing that with your liver enzymes, AST and ALT. And these are within the normal range. The normal range is generally less than 40, right? ALP is usually around 100, or maybe 100, 150, depending on the lab, right? So this is very, very high, right? So the fact that the ALP is very high and the ALT is normal indicates that this is a cholestatic pattern of injury. And when we know ALP can come from bone as well, so if you see a gamma GT which is also elevated, then you are more convinced that the ALP is coming from the liver. And of course, in this patient, the bilirubin is also high, which supports that this is coming from the liver. So this is a cholestatic pattern of injury. Now, is this liver failure?
No, it's not, right? The serum
Yeah, what you
albumin, the serum, so the functions of the liver, from here we can look at the synthetic functions.
Yes.
So the production of albumin. Albumin is at 40. I think around like 30 to 40 should be normal.
That's the normal range, yes.
So normal, and then globulin is also another synthetic function. So that is around
Globulin
20.
is actually formed by your immune cells. Okay.
Right, sorry. INR is at 1.7.
Yes.
So that is again due to the clotting factors. So that's, less than 2 is it's okay, I guess.
So INR is elevated, but you are right. So INR is not necessarily elevated because the liver is not functioning, but rather because the liver is not getting the vitamin K that it needs to produce the active form of the clotting factors, right? So, yeah, so this is not liver failure, right? This is just cholestasis. So the problem is not necessarily in the liver function. Right. So now what would be, so based on our liver function tests also, we are quite convinced that this is obstructive jaundice, right? As we work based on our clinical assessment as well. So what is our next investigation? It's an ultrasound. And here you can see this is just a schematic diagram which shows what you might see on an ultrasound. So basically, if there's intrahepatic cholestasis, which means when we say intrahepatic, we mean bile is not moving from the cell into the bile canaliculi. So the duct system looks normal. Or it can be extrahepatic, which means everything is getting into the canaliculi and then into the small ducts. But due to some obstruction, which can be outside the liver or even inside the liver, depending on where it is, there is dilation of the ducts. If there are ducts dilated, it is extrahepatic. If there's no duct dilatation, it is intrahepatic. So it's important to differentiate between the two because your differential diagnosis differs. Now in this patient, ultrasound reveals a dilated intra and extrahepatic biliary tree with dilatation down to the end of the common bile duct. So what could be going on? We talked about most of the most likely things. So I think you can answer the question.
So according to this, there's an obstruction at the distal end of the common bile duct.
Yes.
Because everything more proximal to it has gotten dilated.
Yes.
So based on that, I would say something in that region. So say ahead of the pancreatic carcinoma or something like that is more likely than a cholangiocarcinoma, something higher up. It could also be that a gallstone has gotten stuck somewhere further down.
Right. So those are the main things that you need to think about. Malignancy and gallstones are the common things, right? And in a young patient, gallstones are more likely than in an older patient, right? But of course, if there are gallstones, generally there's some amount of pain. All right. So what we do know, though, by looking at the scan is that this is extrahepatic cholestasis, or basically there's a problem in the duct system. So either there's a block inside the duct, right? Or there's something within the wall of the duct, or there's something compressing the duct, right? So this again is another schematic, schematic diagram, which shows you the possible differentials, right? And you can use this kind of approach when you're dealing with any kind of obstruction in any kind of tubular structure. So intraluminal, common thing is a stone, right? You can also have a tumor, and what I said ampullary here because it will only really be considered intraluminal if it's covering the lumen at the exit site, right? Otherwise, you can consider it to be intramural, right? So the common things are the CBD stone, right? Helminth, you might have learned for parasitology, right? But it's not very common. Things like ascariasis can migrate into the biliary system. Then when it comes to intramural, you can have a stricture. So basically there's some fibrosis occurring in the tubular wall. So strictures anywhere can be either benign or malignant. So how can you get a benign stricture? If you had an episode of cholangitis, you might get a stricture after that, right? If you've undergone instrumentation like an ERCP, then maybe a few months or years later, you can get a stricture. And then there are autoimmune conditions like sclerosing cholangitis, which can also cause strictures, right? And strictures can also be malignant, like like a carcinoma within the bile duct. And then you can have things compressing the bile duct, like lymph nodes, for example, at the porta hepatis, like a tumor at the pancreatic head, or a pancreatic pseudocyst, right? So these are the different. Okay, so this patient had a gallstone in the CBD. What other symptoms might this patient have had? We already talked about those. So you could have had some pain, biliary colic. So anybody would like to very quickly tell us what a biliary colic might feel like? Do you know? More surgery than medicine, but doesn't hurt to know. Yeah. Where is the pain felt?
It's a right upper quadrant type pain, which is colicky in nature. However, it doesn't reach the baseline, and associated with that, the patient can have some systemic, can feel unwell, can have some fever, and then on examination, Murphy's sign would be positive.
All right. So yeah, so some of those are symptoms of a gallstone, some are complications, right? So some are symptoms of cholecystitis rather than gallstone itself. So if you have a gallstone, you have a stone moving through the, so if it's causing jaundice, it should be in the bile duct, but otherwise it won't cause jaundice, right? So you can have pain, like you said, in the right upper quadrant, and it's colicky in the sense it's not like your ureteric colic, as you said. doesn't really reach the baseline. And does it radiate to any other part of your body? Yes. Where does it radiate to and why? Anybody?
In a biliary colic, the pain usually can radiate across the upper abdomen. If there's a cholecystitis, you can get the shoulder tip and inferior angle of the scapular pain along with epigastric.
Yeah, so even the gallstone can also radiate to the tip of your shoulder or the interscapular region, right? And as you said, into the epigastrium also. So yeah, so it can have the typical pain in that site with the radiation, right? So those are the other symptoms that the patient might have. Now, fever is a complication. Fever you cannot get if there's cholangitis or if the stone is in the gallbladder or the duct of the gallbladder and there's a cholecystitis. So that is separate from obstructive jaundice due to a stone. So what do we do when we find out that this patient with jaundice has a stone in the gallstone? We must refer him to a gastroenterologist who will then probably do an ERCP, right, to remove the stone. Endoscopic retrograde cholangiopancreaticogram, pancreaticogram, and then the stone is removed, right? So can you think of any complications that you would watch for post-ops? I've just put that in because you are going to be intern officers soon. Tell me 2 complications that they can get after the stone is removed.
You can have post-ERCP cholangitis. There could be bleeding, perforation of the duct.
Yeah, so one important thing is cholangitis. If they get fever the next day, that is what you need. That is one thing you need to be worried about, and it can be a very severe infection. Right? Cholangitis is a life-threatening infection. Other important complication?
Pancreatitis, post-ERCP pancreatitis.
Exactly, pancreatitis, right? So we have to keep that in mind. Fine. Now, imagine this same patient who presented with the deep icterus had a normal ultrasound scan. Sorry about that. What would your differentials have been? How would you have investigated? Now, what does it mean if this patient with deep jaundice, which is confirmed to be conjugated hyperbilirubinemia on investigation, right, has a normal ultrasound scan? That means there's no obstruction, right? What does that mean to you in terms of your classification of jaundice?
We can't see the screen.
Sorry, yeah, give me a second. Yeah, so I'm going to go back to the previous slide. Okay, so what does it mean to you? You understand, isn't it? Same patient, deep jaundice, same blood tests. So it's conjugated hyperbilirubinemia, right? But the scan is normal. So there's no obstruction.
So it could be hepatocellular in origin, like say hepatitis or cirrhosis.
Right. So if it is hepatocellular, what do you expect the liver enzymes to be like?
Yes, your ASTs and your ALTs would go up.
They would go up. So we're talking about something else. So remember I said cholestasis can be due to a problem with secretion of conjugated bilirubin into the duct system, or it can be a problem in the duct system, which is clogged. If the duct system is clogged, then you expect the ducts to get dilated, right? And it's then that you see this dilated system on the ultrasound scan. That is called extrahepatic jaundice. So when we say extrahepatic, we don't mean that the obstruction is outside the liver. We mean the obstruction is after the hepatocyte has excreted the bilirubin into the duct system, right? So usually it's a problem within the duct system. The lumen or the wall of the lumen is blocking the flow. But you can also have problems where the liver cells are able to conjugate the bilirubin, but they aren't able to transport that conjugated bilirubin into the biliary system. There are specific diseases like that, right? So in that case, the duct system looks fine because there's no block in the duct system. The block is at a cellular level. Do you understand? So that is called intrahepatic cholestasis because the problem is originating in the liver cells, within the liver cells. So the biochemistry is the same. You can't differentiate the two from the biochemistry. You differentiate the two from the scan. Do you all understand?
Yes.
So if you look here, it may be more clear, right? So in intrahepatic cholestasis, the problem is in this step. Step 4, excretion into bile canaliculus. Right? In extrahepatic cholestasis, the bile has got into the canaliculus, but there's a problem with the flow. Biochemically, you cannot differentiate the two.
Madam, in the latter, where there's a problem in the transporter into the tubes, why would your ALP rise if the tubes aren't being clogged up?
So I can't actually remember the mechanism of the ALP. It comes, if I remember right, from the bile canaliculus.
Yes.
Yeah, but yeah, it does rise in this particular situation, but I can't really remember why. Sorry about that.
That's all right. But then
question.
it's collected inside the hepatocyte, right? The conjugated bilirubin.
Yes, it is in the hepatocyte, and then it basically gets that backflow into the circulation.
Right. Okay. Thank you.
All right. Okay, so now we are left with this patient who had the same picture, right? But had a normal scan. So you may not be that familiar with the different causes, but as many things in medicine, right? So when you come for your rounds, you'll understand there are common ways of approaching differential diagnosis of things, conditions. So when you're thinking of the cause of intrahepatic cholestasis, you can think of infections, drugs, autoimmune. Those are the common etiology. When you're thinking of glomerulonephritis, again, infections, drugs, autoimmune are the causes you think of. When you're thinking of thrombocytopenia, again, it's the same thing. So you can use that pathological sieve to think of the different causes. So there are certain infections that can cause intrahepatic cholestasis. Classically, it can occur in what is called the cholestatic phase of hepatitis A. So a patient can have hepatitis A and then have a hepatocellular type of liver injury, right? And then in the recovery phase, go through a cholestatic phase, right? That's one possibility. Then there are lots of drugs which can cause cholestasis. I've just given one example here, coamoxiclam. And then there are autoimmune conditions which can cause cholestasis, like primary biliary cholangitis or primary sclerosing cholangitis. So primary sclerosing cholangitis, why I have put it here is because in primary sclerosing cholangitis, the duct system is very fibrous. So even though it's a kind of extrahepatic kind of pathology, the duct system is not dilated, right? So that's a fine point. Just understood. Now, the reason for I did that case is to explain to you that cholestatic jaundice can be due to intrahepatic or extrahepatic causes. And the way to differentiate that is from an ultrasound scan. And the reason it's important is because your differential diagnosis will vary. If it's extrahepatic, it's more of a surgical problem. It needs a physical intervention generally for whatever it is to be corrected. If it's intrahepatic, it's more of a medical problem. So depending on the cause, Maybe your history will reveal the cause and you will manage accordingly. Sometimes you need to go as far as doing a liver biopsy, right? If that is clear, we can move on to the next case. Okay, so case 2, young man, again, 18-year-old, university student. This patient has deep jaundice. So it's actually the same picture. Now we know deep jaundice means conjugated hyperbilirubinemia. Of course, we want to confirm that with a blood test, right? So these symptoms have been present for about 2 weeks. He feels nauseated and anorexic. He has low-grade fever and body aches. So we have a bit more history here than we had in the previous case, because now you know a little bit more about evaluating jaundice. So what do these symptoms tell you in a patient who has got conjugated hyperbilirubinemia? Why may he be feeling like this? Feverish, body aches, nausea and anorexia. What are the possibilities? And let's note here that he doesn't have, a kind of pain suggestive of a biliary colic.
Looks like he has hepatitis.
Yes, why do you say hepatitis?
Because he has some nausea and some characteristic loss of appetite as well, along with a low-grade fever and just some generalized malaise and body aches.
Yeah, that's right. So when you hear nausea and anorexia, that means loss of appetite, and especially the patient is jaundiced, you have to think of whether there's a hepatocellular injury, because when the liver is injured, these are very classic symptoms that arise. Okay, of course, I mean, they are non-specific symptoms, so even any infection can make you feel like that, but this history is suggestive of hepatitis. So what do? We get our LFTs again, and again, what type of jaundice is this? So if we zone in on the bilirubins, again, you can see it's the same distribution of direct bilirubin and indirect bilirubin. So this is conjugated hyperbilirubinemia or cholestatic jaundice, right? What can you tell about the pattern of injury here?
The ASTs and ALTs are not rated. They're in the 800s and 900s, and ALP is not too high, and gamma GT is also it's not too bad.
Yes, so the injury is more in the AST and the ALT, and the ALP and gamma GT are slightly high, but they are not, compared to the AST ALT, they're not very high. So if your ALT is normally 40, this is 20 times that, right? Same for your ALT, and your ALP, if we say it's normally 100, it's only twice that, right? So it is a hepatocellular injury rather than a cholestatic injury, right? So is this acute or chronic?
It's acute, right? Because his synthetic functions are all right. Albumin is 40.
Yes. So why is it that we look at albumin here?
So in the long term, if he has chronic liver injury, his albumin level, he'll have hyperalbuminemia.
Yeah, that is correct. So why doesn't the albumin go down
due to impaired synthesis?
Why won't the albumin go down in acute liver failure?
I assumed it takes some time for it to cycle through.
Yes, so that is the reason, right? So albumin has a long half-life, right? If I remember right, it's about 18 days. So it takes time for it to fall. So even if your liver stops working today, it will take some time for your albumin to drop in your serum. But are there any other tests that we can use which use synthetic products of a shorter half-life, which can be affected in liver failure?
The clotting
Clotting factors, yes. So what's the test that we do? It's INR, isn't it? So can you tell me why the INR can be elevated in this patient? There may be two reasons, there may be one reason. Anybody can answer. And if you aren't able to follow, please ask questions. You can ask in the chat if you don't want to talk, right?
So the INR, it measures the extrinsic pathway. So if you take all the clotting factors, I think it's factor 7, which has a short half-life. I'm not exactly sure. I can't recall exactly how short it is. But I think it's a few hours. So that would fall with the acute liver injury, and therefore it will raise the INR value.
Yes,
so that's one possibility.
So it could be, so if the clotting factors have a shorter half-life, so therefore, if the liver stops working, the change that you see in the INR will occur much before the change that you see in the albumin, within hours or days, right? So that one reason why the INR can be elevated could be because the liver cells are not functioning. They're not doing what they are supposed to do in terms of synthesis, which is a feature of liver failure, right? Other thing that may be contributing is that there might be some cholestasis, right? But what we can see is that the hepatocellular injury is much more than any cholestatic injury. So I think here it's probably the INR is high not because of cholestasis, but because of the hepatocellular injury, and the liver cells are now not able to do what they are supposed to do, right? So could this be liver failure? I think it can be, or maybe at least an early feature of liver failure. But what other symptoms might he have if this is liver failure?
Features of like hepatic encephalopathy.
Yeah, exactly. So he can have features of hepatic encephalopathy like drowsiness, sleep inversion, hepatic flaps, right? Okay. Right. So similar to the previous scenario, what questions would you ask to find the etiology? Now we are thinking of hepatocellular injury, right? So what are the causes of hepatocellular injury? So again, you can use the diagnostic sieve that we spoke of.
It could be like viral hepatitis or autoimmune hepatitis, or hepatomas. So you would go around asking if there are any risk factors for hepatitis, such as any blood transfusion, sexual promiscuity.
Of course, now we are trying to, yeah, so you're absolutely right. Okay, so thank you. But remember, now we are trying to see this in the context of this particular patient, right? 18-year-old university student who has come with 2 weeks of feeling feverish, like a hepatitis. What is the most likely cause?
Hepe.
Yeah, I agree. So probably hepatitis A is more likely, right? So infections are an important category. And of those, hepatitis A, hepatitis B, even hepatitis C can cause acute hepatitis. But hepatitis A is more likely and more common also. No? I mean, the risk factors are, we are all exposed to hepatitis A risk factors, right? Because it's all related to hygiene. That's one possibility. What are the other possibilities? It can be an infection. Among infections, viral hepatitis are likely. Any other possibilities? So you mentioned autoimmune. Yes, autoimmune hepatitis is possible, right? So more likely in a woman, right? So if we are thinking of hepatitis A, what are the other questions you can ask in your history?
Places where he's gone out to eat, whether his friends have similar symptoms.
Yeah, very good. So about food hygiene, isn't it? And whether there's any contact with symptoms with anyone with symptoms like this. Yeah. What else? So hepatitis, something that is causing inflammation in the liver cells, infections, autoimmune. What are the other possibilities?
It could be like non-alcoholic state hepatitis or alcoholic state hepatitis.
Okay, so it can be alcohol, right? Alcoholic hepatitis. What kind of, if you were to put alcohol into a category, what category would you put it into? You can call it a toxin, right?
Okay.
So usually we talk of drugs and toxins together. So drugs and toxins are an important cause of liver injury, right? So among toxins, when it comes to the liver, alcohol is very important, right? Any other toxins that you can think of, drugs or toxins?
Paracetamol overdose.
Paracetamol is important, right? So young patient, that's something to suspect. But generally, of course, they are ill. If they are, if their liver injury is so bad that they have jaundice, they'll be very ill. Okay? So paracetamol overdose is something to consider, though. Anybody with hepatocellular injury, which is otherwise unexplained. What else? Okay, so we'll move on to the other causes, I think, on the next slide. But in this patient, I think we agree viral hepatitis is common. So if you think of the epidemiology, male, young, university student, that is the first thing that should come to your mind. Of course, anything else is also possible, and we'll go through that in a little bit more detail. Now, if you were to examine him, apart from his deep icterus, another physical finding you might expect is right upper quadrant tenderness with hepatomegaly. Now, why do you think that he will have hepatomegaly, and why will it be tender?
The inflammation is causing the stretching of the liver capsule.
Yeah, that's the reason, right? So when the liver capsule gets stretched acutely, it becomes painful, right? So there aren't a lot of causes of tender hepatomegaly. Acute hepatitis, for whatever reason, can cause tender hepatomegaly, right? And you can think of a few other differentials also, right? So that you can figure out how you are going to approach a patient with tender hepatomegaly. All right, so how are you going to investigate this patient? For hepatitis A, what is the test that you are going to do? Before moving to hepatitis A, is there another test that you want to do? Just as part of your assessment?
So first, I would like to exclude hepatitis B because it's more severe. So a hepatitis B surface antigen would be a starting test, and then hepatitis A. I think it's the IgM antibodies, which is the test for hepatitis A. Yeah, and also hepatitis E might be a possibility, but I can't recall the test, madam, because that's also very similar to A.
Right, okay. So yeah, hepatitis A, generally we use an IgM, right? That's correct. Would you do an ultrasound scan abdomen in this patient? I think yes, right? Because he does have conjugated hyperbilirubinemia. It's worthwhile doing a scan just to make sure that there's no obstruction. Obstruction, if it's acute, can give rise to very high liver enzymes, but of course you'd expect the ALPs and the bilirubins to be higher than this, but you can always be surprised. So in practice, we would probably do an ultrasound scan on this patient just to look at the liver and make sure that there's no duct dilatation, just as a part of the management, right? Even though we'd expect it to be normal in hepatitis A, which is our main differential here, right? So just to sort of recap the causes of hepatocellular liver injury, we mentioned some infections, right? So we talked about some viral infections, and when it comes to bacterial infections, something you can think of is leptospirosis, which generally though causes more of a cholestatic picture than a hepatocellular picture. So your liver enzymes will be not as high as, say, your ALP and your bilirubin, right? Then we spoke about drugs and toxins, right? So sometimes patients can be very well, look very well and just have jaundice. Sometimes patients are very ill and have jaundice. So if there's hepatocellular injury, they are more likely to be ill as well. Whereas if it's just pure cholestasis, they're not that unwell. Okay. So when it comes to alcohol generally doesn't make your AST and ALT go up as high as we saw it was in this patient. They'll be around 300, right? So that is when you see values in that range, you should think of alcohol. Paracetamol overdose we spoke of, and then there are lots of other drugs, antibiotics, antifungals, antiepileptics, which can cause liver injury. Some are cholestatic, some are hepatocellular. Autoimmunity we mentioned, right? And here are some other causes. So ischemia is an important cause of hepatocellular injury, right? But if patients have jaundice due to ischemia, again, they will be very ill. So you wouldn't have a patient walking into the clinic with ischemic hepatitis. It's unlikely, very unlikely, right? So it can be either low blood pressure, or sometimes people have normal blood pressure, but because of back pressure, right? Congestion, maybe in heart failure, they can have very high liver enzymes, a hepatocellular kind of injury, which if severe can be associated with jaundice. Acute hepatitis can occur rarely in Wilson's disease. Wilson's disease will affect generally young people. 18 years is still possible, I suppose, but it's rare, right? So definitely not one of the first things that you are going to think about. Hereditary hemochromatosis is not an acute problem, it's a chronic problem, right? It can cause abnormalities in your liver, but not an acute hepatitis. And then there are certain infiltrative diseases of the liver, like granulomatous diseases like TB and sarcoidosis, amyloidosis, malignant infiltration, right? So these generally don't cause much elevation in the liver enzymes or the transaminases, but they can cause elevation of ALP and gamma GT. And often these are elevated much, much more than the bilirubin, right? So if you see somebody who has very high ALP and gamma GT, but relatively the bilirubin is not that high, you can suspect an infiltrative disease, right?
Madam, a lot of those conditions in your previous slide, in this slide, they're quite chronic conditions, right?
So some of them are chronic. So
Like
infiltrated things will be chronic. Yeah, and infiltrative diseases won't really cause hepatocellular injury. It's the cholestatic injury, right? So others,
Right, okay.
infections are acute. Drugs and toxins are generally acute. Ischemia is acute. Autoimmunity can be acute, can be chronic. Inherited Wilson's rarely can be acute. Hemochromatosis is not acute. And infiltration also won't be acute, right?
Right, thank you.
Okay, so that is the second case. Anybody has any questions on that? So that was about hepatocellular jaundice, right? So if the patient has jaundice due to a hepatocellular injury, usually they will be ill. They will feel ill because the liver, because they have jaundice because the liver is not working properly, right? And there are certain causes of hepatocellular injury, which may differ according to the type of patient, certain age groups, then male versus female, right? All right. So we'll move to the next case. This is a young woman, 28 years old, presenting with mild yellowish discoloration of the eyes. So I admit this picture probably isn't very good. But what I was trying to show here was mild icterus, right? She also feels a bit tired. Okay, so I think we agree that there's jaundice, right? So what sort of tests would you like to do on her? Now, your first step when you have somebody with jaundice is to differentiate between unconjugated hyperbilirubinemia and conjugated hyperbilirubinemia. So how are you going to do that?
You need to check her serum bilirubin levels, the direct and indirect ones.
Yes. So here you can see there's total bilirubin is 6, indirect bilirubin is 4. So is this conjugated or unconjugated?
It's unconjugated.
Yes, it is unconjugated because direct bilirubin is only 2 and it is less than 50%, right? So even in a normal profile, your unconjugated bilirubin will be high. So it can even be 80-90%, right? That is when it's in the normal range. So here it is clearly in the abnormal range, right? And it is predominantly unconjugated. Rest of the liver profile is now normal, right? So what does unconjugated hyperbilirubinemia mean to you?
Excuse me, madam, one small question. Regarding the conjugated and unconjugated hyperbilirubinemia, isn't it by definition when you tell a patient has direct hyperbilirubinemia that the conjugated is more than 20% of the total bilirubin?
50%. So I know some books, I think maybe the Harrison says 20%, but more recently they say 50%.
Okay, thank you.
The rest of the liver profile is normal, right? What will you do next?
So in this patient, I'm thinking of a hemolytic type of jaundice. So maybe a full blood count would be prudent to check for anemia.
Agreed, right? So you want to do a full blood count. So what do you think of this full blood count?
She's anemic. Hemoglobin is 9.
Hemoglobin is 9 and MCV is it normal or high or low?
MCV is high.
MCV is high and the white cells and the platelets are normal, right?
Yes.
Right. So she has a macrocytic anemia. What is the next step? Now you are trying to decide whether there's a hemolytic anemia or not.
To look at the blood picture.
Yeah. So blood picture shows some spherocytes, right? reticulocyte count is elevated, right? So what does that mean to you?
So that confirms my suspicion of a hemolytic type of anemia with compensatory reticulocytosis.
That's right. And spherocytes, what does that suggest? Any differentials with spherocytes?
Thinking of hereditary spherocytosis.
It can be hereditary spherocytosis. Any other differentials? So it can also be autoimmune hemolytic anemia, right? So you differentiate the two by doing a Coombs test. So this patient's Coombs test is negative, right? And we come to, let's say we do an osmotic fragility test as well, and we come to a diagnosis of hereditary spherocytosis, right? So it looks like it's a hemolytic anemia. She undergoes an ultrasound of the abdomen and she has splenomegaly, which is in keeping with your diagnosis of hereditary spherocytosis. Incidentally, she also has gallstones. Now, are these a coincidental gallstones? What do you think?
No, they could be due to the increased production of unconjugated bilirubin, which is taken up by the liver, and the conjugation process is ramped up. So there's increased conjugated bilirubin being secreted into the bile canaliculi, and also then they're stored in the gallbladder.
That's right. So it's because of the hyperbilirubinemia, isn't it? So it is a complication of chronic hemolytic anemias, right? So just because there's gallstones, that does not mean that the hyperbilirubinemia is conjugated, but it is a consequence of the hemolytic process. Okay. Now her friend has also noticed that she has yellowish discoloration of her eyes on and off, right? She feels well. So the other lady felt tired. This friend feels well. She also has an LFT, and she has the same breakdown of total bilirubin and indirect bilirubin, right? So I think we agree that she has unconjugated hyperbilirubinemia, and we suspect that she also may be having a hemolytic anemia. Rest of the liver profile is normal, so still in keeping with our suspicion of hyperbilirubinemia, right? Sorry, of hemolytic anemia. So what you do, you suspect hemolytic. Sorry, I got disconnected again. Just give me a second. Right. Anybody? So are there any other tests that you can do to exclude hemolysis? Are you happy?
Madam, you could do LDH.
You can do an LDH, yes. So let's say that's also negative, right? And you have hemoglobin level, right? So that's also negative. So you have reasonably excluded hemolysis. So what can be going on?
So then it could be one of those rare causes where there's a decreased uptake of unconjugated bilirubin. Yeah.
Yeah. Do you know any of these rare diseases?
Is Crigler-Najjar one of them?
Crigler-Najjar is one, right? But the more common one is Gilbert syndrome.
Right, that's
right?
one, yes.
It's maybe not very rare. We see patients every now and then who are perfectly fine, and maybe incidentally they have hyperbilirubinemia on a blood test, right? They may not have jaundice. Some of them will have jaundice on and off. No evidence of hemolysis, otherwise they're perfectly fine, right? And then you come to a conclusion by exclusion that they have Gilbert syndrome, right? So this is just to tell you about the importance in that step. So unconjugated hyperbilirubinemia can be due to either increased synthesis because of increased hemolysis, or due to reduced uptake by the liver cells because of a genetic problem like Gilbert syndrome. Okay? All right. Okay, another case. This patient comes to you complaining of yellowish discoloration of the skin. What do you think this might be? Any comments?
It could be jaundice, but it could be something else as well.
Why do you think, okay, it could be jaundice. What is for this being jaundice? Or what is against this being jaundice?
If the palms are yellow, I'm assuming this person's palms are the ones which are yellow, then the eyes should be yellow as well, because that's just how it goes down.
That's how it goes. You can see that her eyes are not yellow, they're white, right? So because she has yellow palms, you do a bilirubin anyway, right? Just to be sure, and you find that they are all normal. So what could this diagnosis be? Yellowish discoloration without hyperbilirubinemia.
Could it be hemochromatosis?
Hemochromatosis, usually it's like brownish pigmentation.
It could be beta-carotenemia.
Yeah, it can be beta-carotenemia, right? So if you eat a lot of carrots or pumpkin or anything with beta-carotene, this can happen, right? And that is the diagnosis in this scenario. All right. So we've gone through some cases. Let's just recap what we learned, right? So when it comes to jaundice, this is from your Kumar and Clark. It can be something occurring prior to the liver or something occurring after the liver, right? Prior to the liver, pre-hepatic due to hemolysis. After the liver can be either in the biliary system or in the liver, within the liver or in the biliary system. When we're talking about within the liver, what are the things we need to think about? Infections like viral hepatitis, viral infections, drugs and toxins. And under toxins, we can include alcohol. Cirrhosis of any type can cause jaundice, right? Because the liver is not functioning. When the liver fails, you can get hyperbilirubinemia, but usually it's in the late stage, right? Autoimmune diseases can cause jaundice, right? So autoimmune hepatitis, autoimmune diseases of the biliary system. Pregnancy has unique causes of jaundice, right? And then some congenital disorders that we mentioned, infiltration, right? And then extrahepatic, in this biliary system, you can have a variety of causes. So we did a more detailed breakdown of the differentials before, but just to recap, stones in the common bile duct. So stones in the cystic duct will not cause jaundice because there's a clear pathway for the bile to flow, right? So for there to be jaundice, the obstruction should be somewhere in the bile duct, common duct. Carcinoma of the bile duct can cause jaundice, carcinoma of the head of the pancreas or the ampulla where the bile duct drains out into the duodenum. They can all cause jaundice. A stricture of the bile duct can lead to jaundice. Sclerosing cholangitis, that's a specific condition, right? And pancreatic cirrhosis, which is, compressing the bile duct. Okay, I hope that's clear.
Madam, didn't we just, in a previous slide, put sclerosing cholangitis on top as an intrahepatic cause?
Yeah, so on that, though I said intrahepatic, it's what I meant. So if we go back to that slide, I was talking about the scan findings, right? So because it's a sclerosing condition.
All right, you were saying the ducts are not dilated.
Ducts are not
Right?
dilated.
Yeah.
Okay. Oops. Right. So this slide, I hope you can see it from the American College of Family Practitioners, right? It's about the approach to a patient with jaundice. So let's just have a look at what they say. Patient appears jaundiced, you are going to perform a history and physical examination. So I think it's a good idea for you to, when you have some time, maybe today, maybe within the next couple of days, to think about what we have learned today and how you are going to plan your history taking and examination in a patient with jaundice, because it's a very clear physical sign, and the differentials are limited, right? So it's worthwhile, thinking a bit about it, and maybe writing down the questions that you would ask and the physical examination that you would do in a patient with jaundice. So once you've done that, you would do some lab tests. So you do the fractionated bilirubin so that you can differentiate between the two. Full blood count, right? For obvious reasons. So for example, if it's a hemolytic anemia, there might be anemia. And then when it comes to differentiating the other causes also, it can be useful. Then you will do a full liver profile with ALT, AST, ALP, gamma GT, INR, albumin, and when you say protein, you mean globulins here, right? So full liver function test. Now, if everything comes back normal, including your bilirubin, that means this particular appearance, which we thought was jaundice, is not due to hyperbilirubinemia. So it's something else. So could it be skin color, spray tanning products, carotenemia, and these other conditions, right? So that's not the topic for today, but if that's what to consider, if the lab investigations are normal. If you have increased total and indirect, or rather if you have unconjugated hyperbilirubinemia, right, you are going to look for hemolysis. What can you do? You can do a blood picture as you did. There might be specific features. You can do a direct antibody test if there are spherocytes to look for autoimmune disease, autoimmune hemolytic anemia. You can think of G6PD deficiencies, enzyme testing depending on the case. Look for other features of hemolysis like we mentioned. If there's hemolysis present, that is the cause of this jaundice, and you treat that cause. If it's not present, you can think of Gilbert syndrome, or less commonly Crigler-Najjar syndrome, right? Now, if you have conjugated hyperbilirubinemia, right, then you know it is either hepatocellular or cholestatic, right? So you can, when you're thinking of this, now you're going to do the liver profile as part of your initial workup, right? And you will do your lab assays for viral hepatitis and consider imaging, right? So imaging, ultrasound is the first test that you are going to do rather than, say, MRCP or CT abdomen. Ultrasound gives you a data. So viral hepatitis or other cause identified, you treat. Could be gallstones, could be a stricture, and so on. If you have no diagnosis based on your preliminary screen, you can do added tests. So if you want to, so you may have to revisit your history, remember, so you might have to go back and probe. Are you sure you didn't take any medications, any Ayurvedic medications, that kind of thing, to come to a diagnosis? And then you may have to do some extra tests, right? So depending on your clinical suspicion, to differentiate between the causes that we described earlier, right? You might have to do some cancer testing, some further biliary imaging, autoimmune antibodies assays, and so on, and maybe even eventually a liver biopsy, right? And your management will depend on the cause that you find. All right, so this is like a very basic overview of how you would approach a patient with hyperbilirubinemia and jaundice. Do you all have any questions to ask? Okay, so that's the end of the class. Any questions?
Madam, apart from primary sclerosing cholangitis, did we talk about any other causes of this indirect this intrahepatic cholestasis?
Yeah.
Right.
So it can be infections, right? We talked about the cholestatic phase of hepatitis A, right? I mentioned it can have a more cholestatic pattern. So patients can be jaundiced. You do a scan. They can be jaundiced. It can be direct hyperbilirubinemia. You do a scan and the biliary tract spirosis is another possibility. Lots of drugs that can cause it. One is primary biliary cholangitis is the typical scenario, right? And then primary sclerosing cholangitis also.
All right, perfect. Thank you.
All are ready to tackle jaundice now? Okay, so if you don't have any questions, we can stop there, right? Okay, then. Okay, bye, everyone.
Thank you.
Thank you.